I'd share highlights a few things about the thiopurines. So this is a 21-year-old man. He's actually studying to be a mechanical engineer, no significant past medical history. And he presented to our clinic in August of 2021 with 11-month history of bloody diarrhea, passing 8 stools a day, associated with tenesmus and urgency, also lower abdominal cramps and 4-kilogram loss of weight. He was a non-smoker, he doesn't take any alcohol, and no family history of note. He has no travel history and had not taken any antibiotics. Clinical examination was really unremarkable. He had a weight of 60 with a normal body mass index. His HB was low, which was in keeping with an iron deficiency anemia, low ferritin and a low MCV. CRP was 25. He was HIV negative, varicella zoster IgG positive, and EBV IgG positive. Dual MCNS, there were no pathogens, and C. diff was negative. Abdominal X-ray showed an ahaustral colon without the presence of a toxic megacolon, and he had an endoscopy to the cecum, which was in keeping with moderately severe ulcerative colitis. And histology confirmed UC and excluded a CMV. So the diagnosis was made of moderately severe extensive ulcerative colitis. He was started on prednisone, 1 milligram per kilogram, vitamin D and calcium, and he was given intravenous iron. He was also treated with cilazopyrene, 2 grams BD orally, and 5 aminosalicylate suppositories. And he responded well and achieved clinical remission, and the corticosteroids were tapered and were stopped. But then in January of 2022, he had a second flare of his ulcerative colitis, again treated with prednisone, and as customary, if someone has more than one flare requiring steroids, they need to go on a steroid-sparing agent, and so azathioprine was started at 100 milligrams per day. His TPMT genotype was checked, and none of the common mutations were seen. And this is just a list of his serial blood counts that were done during the months that followed. And you can see in August, his lymphocytes start to drop a little bit. That's what we want to see. Remember, I said if you have a slight lymphopenia, it means that the drug's probably therapeutic. Similar in September, but then in December, out of the blue, after 12 months on azathioprine with not a problem at all, he suddenly drops his white cell counts to 2.34, his neutrophils to 0.65, and his lymphocytes to 1.7, and he also has a slight thrombopenia. So the azathioprine was stopped for a week. His full blood count was rechecked and it was normal. So he was started on 50 milligrams a day, so half the dose that we initially commenced him on. But on restarting, he developed GIT side effects, nausea and vomiting and abdominal pain. So we switched him to 6-mercaptopurine, 25 milligrams. Remember, the dose is half that of the azathioprine. And this was well tolerated, and he's been on it for some time in deep remission with no further episodes of neutropenia. Right, so I'm going to end off there, and I'm then going to hand over to Moosa, who can present his case. Thanks, Moosa.
Thank you, Prof. Let me just share my slides first. Good evening, everyone. Thank you for the opportunity to present in today's IBD session. Can you see my slides?
Yes, we can.
All right, let me just. All right. So the case I'm presenting is of a young patient, 30-year-old male, who's been with us for quite a long time. He's a complex and a long medical journey with us. And he has a background history of, he's HIV negative. He's a smoker with a history of alcohol use as well. He was diagnosed as a juvenile arthritis at the age of 9. And then previously he had a history of pulmonary TB as well in 2009, which was treated. So he was diagnosed with Crohn's disease in 2012. Initially, it was only limited to the right-sided colon, non-stricture. But subsequently, his disease evolved an ileocolonic involvement with the stricturing phenotype. His initial presentation to us was in 2011. Initially referred to us because of the chronic abdominal pain and iron deficiency anemia. As part of the workup, he underwent a gastroscopy as well. Initial gastroscopy showed esophagitis with enteral erosions and normal duodenum. But which he was treated with a PPI and eradicated, and subsequently which resolved. Because of the symptoms and the anemia, he also underwent a colonoscopy. His index colonoscopy showed right-sided colitis with a normal terminal ileum. Histology confirmed with a normal TI with a colonic biopsy showing granulomatous inflammation. Although the AFP was negative and the TB culture later came back as negative. Given the location of the involvement, as well as he was on immunosuppressant, he was, for the rheumatoid arthritis, he was already getting the low dose of methotrexate and the low dose of prednisolone as well. So he was, and he had a history of TB before. He was treated empirically with a TB treatment. And at the same time, he was also started with the mesalazine as well to cover for the colitis. So despite about 2 months history of TB treatment, his symptoms did not improve. In fact, ongoing nausea, abdominal pain, and then his weight has also started coming down as well. So repeated colonoscopy, which this time around, which has shown a more extensive disease up to the splenic flexure with a distorted anatomy as well as a chronic inflammation, pseudopolyps suggestive of chronic inflammation. Again, histology this time around as well showed active colitis with ulceration. TB was negative as well. So based on the repeat endoscopy, we have committed to the diagnosis of Crohn's colitis and then given full dose of steroids for induction of remission for Crohn's colitis, as well as we increase the dose of methotrexate to treat for Crohn's. Even though he was given this treatment, he also completed the empiric TB treatment by mid-2012. So from 2012 until 2015, he was treated with the methotrexate. Initially, it was oral. Later, because of a poor response clinically as well as endoscopically, the dose was, his medication was changed to parenteral route subcutaneously. Initially 25, then subsequently maintained at 15 milligram weekly. Early 2015, he presented with a flare of Crohn's disease. This time around, it was a difficult colonoscope. The findings were active disease on the right side with a distorted and a very friable mucosa and easy bleeding as well as lots of pseudopolyps. Unfortunately, this colonoscopy was complicated with a bowel perforation. He underwent urgent right hemicolectomy with end-to-end anastomosis. He was well, was discharged, presented again in early 2016. Of course, post-operatively, he was on maintenance methotrexate as well. Symptomatically, he improved. However, looking at his biochemical features, he still remained anemic with iron deficiency as well. He was given IV iron supplementation, and a repeated colonoscopy during this time around showed TI involvement as well as segmental inflammation in the distal transverse colon. Histology also confirming the active inflammation as well. So during this point of time, he was on 15 milligram of methotrexate. I think that there was unavailability of parenteral methotrexate. So he was on oral methotrexate 15 milligram, which was subsequently increased to 25. There was no clinical improvement with the increase in dose. However, his GI side effects was increased. Hence, the decision was made to divide the dose so that the side effects might be reduced. Unfortunately, there was no biologic slot available even at that point of time. So then later, in October 2016, he presented with an acute pancreatitis. This time around, a clinical history of 2-day history of typical pain, history with epigastric pain which radiates to the back, and then biochemically elevated lipase with the inflammatory markers, and confirming that he has acute pancreatitis. Other relevant investigations, calcium, liver profile were done, but which were unremarkable. Imaging was done during this admission, which showed the features of acute pancreatitis with extensive intra and retroperitoneal fluid, but there was no discrete collection. And unfortunately, during this presentation, he was complicated with the portal vein as well as splenic vein thrombosis. Then imaging features, there were no features to suggest that cholelithiasis on any of the imaging during that presentation. He was managed like any other acute pancreatitis with the IV fluid, analgesia, as well as nutritional support. His symptoms resolved. for the thrombosis, he was given therapeutic anticoagulation with Clexane initially, then subsequently warfarin was given. Before discharging, a week later, again, another repeat imaging was done just to confirm that there was no evidence of cholelithiasis, and then to assess for if there's a need for intervention as well. So the pancreas was grossly edematous and then enlarged, is seen on the previous CT, and then was discharged well. A month later, he presented with a supratherapeutic INR of 4.8 with a lower GI bleeding. Hemoglobin this time around was 4.4. On discharge, it was 8.8. His clinical examination was unremarkable except for the pallor as well as the tachycardia. Local examination with rectal examination was also unremarkable. He was transfused with the blood products. Warfarin was stopped because of the bleeding and the supratherapeutic INR. And the repeat imaging was done to assess to decide on whether to continue with the anticoagulation or not. So fortunately, the portal vein was patent this time around with a normal velocity, and the documented pancreas was normal, and then there was no calculi in the gallbladder as well. So given that he presented with an acute bleed, lower GI bleed, so he underwent a colonoscopy which showed active disease with a severe ulceration extending to the involving even the descending colon as well as rectosigmoid junction large ulcer, which histologically consistent with the chronic active colitis. Unfortunately, given that he was on methotrexate and with this poor response, we were left with no choice as there was no biologic available at that point of time. There was no slot for biologics for him. So there was no choice except, even though he's a young patient, young male patient, he was started on methotrexate. Azathioprine was started after stopping methotrexate. Initially started with 50 milligram per day while waiting for the TPMT results, which came back later as a normal TPMT. He was also screened for opportunistic infections, as Prof has mentioned just now. His EBV IgG was positive, as well as varicella zoster IgG was positive. He was HIV negative, hepatitis B and C were negative as well. So he was reviewed 2 weeks after starting azathioprine is like any other case. There's no signs of any myelosuppression on the cell counts. And AZA dose was hence increased to 75 milligram per day with a plan to review in 2 weeks with a repeat CBC. So 4 weeks after starting the azathioprine, he presented with acute pancreatitis again. So this time presenting with a 1-day history of upper abdominal pain and clinically tender epigastrium with a elevated lipase of 1529. His CRP was also elevated, along with because this is the second episode, we did other investigation as well, triglyceride, his calcium, immunoglobulin G4, as well as ANA, but which were unremarkable. He denied any history of alcohol or drugs, apart from, he's not any other medication except azathioprine that could contribute for his pancreatitis. So CT was done later on, which showed small pancreatic neck pseudocyst, but this time around again, CT shows the resolution of occlusive portal vein as well as splenic vein thrombosis. His symptoms resolved and was discharged. Azathioprine was stopped because of this pancreatitis, and then subsequently restarted back on methotrexate with a 25 milligram with a plan to monitor pseudocyst with the imaging. Few months later, required drainage of the pseudocyst and the repeat colonoscopy, again, active colitis with a transverse colon stricture, which was not there in the previous endoscopes. So we believe that this episode of acute pancreatitis is most likely due to the azathioprine, given that he was recently started on azathioprine just 4 weeks back, and this time around he denied any alcohol intake, and there was serial imaging with no evidence of cholelithiasis, and his calcium, triglyceride, and IgG4 were normal. And he had a multiple cross-sectional imaging as well as upper GI endoscopies done, which did not show any evidence to suggest a duodenal Crohn's disease as well. And fortunately, August 2017, we were lucky to get infliximab for him. This time around, again, prior to starting the infliximab, endoscopically he had active disease with active colonic inflammation with a narrowing of transverse colon with a sigmoid ulcer as well. He was started with infliximab 5 mg per kg, 8 weekly with INH prophylaxis. Methotrexate was continued at a 15 mg per weekly for immunogenicity as well. His weight has improved and he was doing clinically well. Until early 2020, he presented with a partial bowel obstruction, which resolved spontaneously. At that point of time, he had a cross-sectional imaging with an MRE, which showed a 7 centimeter tight stricture in the transverse colon with a peristenotic dilatation and active disease in the proximal as well, with continuous to the stricture. So this time around, we checked his therapeutic drug level. Unfortunately, it was low with no antibodies. So the dose was changed to 6 weekly from 8 weeks. And the repeat colonoscopy after increasing the dose of the infliximab a few months later, the persistent structure was there with multiple pseudopolyps with a surrounding normal mucosa. Histology of the mucosa showed normal mucosa, no active colitis on the histology. Over the last few years, his infliximab dose has been gradually increased, and his latest MRE to assess his disease was done end of last year, which shows persistent transverse stricture, but there were no active disease on the MR radiologically. And the last dose escalation was in March this year. Now he's on 10 mg per kg every 4 weeks, as the drug level was subtherapeutic with infliximab of 2.06 with a no negative antibodies. And he was reviewed, last seen in the clinic few months back, was doing well and received the last infusion of infliximab early this week. And this time around, we repeated another therapeutic drug monitoring just to see how his drug levels are, whether any need is there to change or not. In summary, this is a 36-year-old male smoker who has history of juvenile arthritis and a previous history of pulmonary TB. He is diagnosed with a Crohn's disease, with currently ileocolitis complicated with a stricture. He also had a history of right hemicolectomy for iatrogenic colonic perforation with subsequent post-op recurrence. He had a poor response to methotrexate and also had a history of ethanol as well as azathioprine-induced pancreatitis complicated with a pseudo-cyst recurrent drainage. He's currently on infliximab with a good clinical response. He's having an extraintestinal manifestation of disease in iron deficiency anemia. So I will talk about azathioprine-induced pancreatitis. So pancreatitis in general is higher, compared to the general population, it is high in IBD patients. There was a study in the Danish population looking at 16-year. They noticed that the patients with IBD are at increased risk of developing pancreatitis, higher risk. Especially Crohn's patients had a fourfold increase in risk of acute pancreatitis, and UC patient had a twofold increase compared to the general population. The most common causes of acute pancreatitis, even in this population, is gallstone and alcohol, just like any other patient. Although in patients with Crohn's, there is an increased risk of gallstone as part of the disease complication. They are also prone to alcohol, and medications contribute to the pancreatitis, especially thiopurines, and sometimes some patients are associated with the 5-ASAs as well and other medications as well. And especially in Crohn's patients, sometimes duodenal Crohn's disease may be a reason for them to develop acute pancreatitis. Of course, other etiologies like autoimmune pancreatitis and hypertriglyceridemia, as well as hypercalcemia, and procedure-related like double balloon enteroscopy or ERCP are also be seen in this population as well. So clinical picture is similar to any other cause of acute pancreatitis. The disease can be diagnosed like any other population with a revised Atlanta classification to have 2 of the 3 criteria: upper abdominal pain and elevation of amylase or lipase 3 times upper limit of the normal, and the consistent radiological features. So azathioprine has been implicated as a definitive cause of drug-induced pancreatitis. Between 4 to 7.5% of patients treated with IBD develop azathioprine-induced acute pancreatitis. Although azathioprine is used in multiple other clinical conditions, the acute pancreatitis is rarely reported in cases except in IBD patients. The patients who develop azathioprine-induced pancreatitis usually have underlying other factors as well responsible for pancreatitis. The exact mechanism is not known so far. It is believed to be idiosyncratic, dose independent, and that there's no correlation with the myelosuppression, suggesting the etiology must be independent of the TPMT activity. There has been some suggestion that it could be a type 2 or type 4 allergic reaction, and that usually the patients present within first 3 to 4 weeks of treatment. Just like in our case, the patient presented 4 weeks after initiation of the treatment. Smoking is again a risk factor for development of azathioprine-induced pancreatitis, again, in our patient who is an active smoker. And the other risk factors noted are female, gender. The natural cause of the disease is usually mild. In case of thiopurine-induced pancreatitis, the thiopurine should not be immediately stopped, and rechallenging should not be attempted. And usually, even if rechallenged, they usually develop the pancreatitis very rapidly. Thank you.
Great, thank you very much, Moosa. Can you stop screen sharing? That's fantastic, thanks. So I don't see any questions yet in the chat. So just to mention, I presented the case of myelosuppression just to highlight the fact that you cannot stop monitoring for the white cell count and doing your full blood count, because this reaction can occur decades after starting azathioprine. So it's just something that you have to carry on doing, unfortunately. And then Moore's case, we decided to present because it was complicated. The first one was related to alcohol, and the second one was azathioprine. So unusual for somebody to have two completely different causes of pancreatitis. So Moosa, I just wanted to ask you, and I'm not sure, I don't know the answer to this. Is having had a previous bout of pancreatitis due to another condition like alcohol, does that increase the risks of developing azathioprine-induced pancreatitis that you came across in your reading at all?
I did not come across it, but then where some suggested actually not to consider initiating, because none of the guidelines are very clear on that. I mean, I think one of the thing is British, if I remember correctly, that they mentioned something about it, but I mean, not very clearly about that it's absolutely a contraindication. But if you have a pancreatitis with any of the thiopurines, you're not supposed to rechallenge with another one. Just like in myelosuppression, you can, nausea and vomiting, GI, other side effects, we can rechallenge with the 6MP. But in azathioprine, we are not supposed to rechallenge.
Yeah, absolutely. It must never be used again. Azathioprine 6MP or any thiopurine should never be used again. Okay, and then the other thing, again, I also don't know the answer to this. So, why is azathioprine-induced pancreatitis more common in IBD than it is in other conditions that also use azathioprine?
Again, not very clear. Some, allergic reactions, some maybe some hypothesize that really probably even it's more common in Crohn's disease. So probably the underlying pathophysiology of the Crohn's may be contributing to the disease itself. The exact answer is.
Well, thank you very much. That was an excellent presentation. Does anybody have any questions or comments that they would like to ask or contribute? I think these set of drugs, they may be very archaic in other countries across the world, but across Africa, of course, they're often the only option that we have, and that includes our unit now. We have no new access to biologics at the moment. So our newly diagnosed patients or complicated patients, they either get azathioprine, 6-mercaptopurine, or methotrexate if it's Crohn's. So we need to still use them properly and know how to use them, because they're probably going to be all that we have until prices come down significantly of the more advanced therapies, which is not happening anytime soon. Any comments? Moaz, anything else you want to mention about that I perhaps didn't mention in your reading?
Nothing that I can think of. I mean, one of the thing was actually duodenal Crohn's disease, but in this patient, I've never seen any, except I think one patient in our Crohn's patient with the duodenal Crohn's. This patient in particular, we had multiple endoscopies and the imaging as well, but there's nothing to suggest Crohn's upper GI Crohn's to cause for the pancreatitis. And the other thing is, I wanted to highlight, apparently the lipase and amylase may be elevated in asymptomatic patients, especially in IBD patients. So the recommendation is actually, if the patient is not symptomatic of typical pancreatitis, we are not supposed to routinely check the amylase unless the patient is symptomatic.
That's a very good point. Very good point indeed. Okay, well, in that case, there's nothing else that I can add. So I would just like to thank Moaz for helping me out at the last minute as we were struggling to fill the session. Thank you to iEcho, University of New Mexico and the iEcho India team. And of course, thanks to the GI Foundation, in particular Chris, for his support of continuing medical education. The recordings are available on the Gastro Foundation website. I'd like to also thank the sponsors and of course, Cheryl and Karen, sorry. So next week, the GECO meeting will be pathology, same place, same time. So have a good evening, everybody, and we'll see you in a few weeks' time.
Thanks a lot.
Thanks,
Excellent,
Cheryl.
Moaz.
Bye-bye.
Thanks, Joel.
Okay. Thanks, Moaz.
Thanks. Bye.